Hi, how are you today? Good. Okay. Uh, Please open your microphones. I want to ask you about how this class will, how you want this class to continue now when we have the VR system available, okay? So I want you to tell me about it. First, let me share. Okay. Before discussing today's lecture, if you look at the apps in Precision OS platform, there are several types of surgeries. Intramedullary nailing, knee arthroscopy, shoulder arthroscopy, ACL reconstruction, anterior cruciate ligament reconstruction in knee, different spine surgeries, different shoulder arthroplasties, different knee arthroplasty system, and different hip arthroplasty system. Uh, Personally, I like to continue as we have done before. For each session, we select a topic, like this session is intramedullary nailing. I give a lecture, introduce the intramedullary nailing and different aspects of it, and show you some videos to become familiar with the concept. And then you have time to uh, to practice on the VR system on your own, not here, not in the class. So when our class is finished, you have 1 week to go to that specific module, for example, intramedullary nailing, and practice on it and see how intramedullary nailing is inserted and what is the operation setup and the size of the incision. So when you want to design an insertion device, how big it should be, what are the angles of insertion. So it will give you a view about the surgical field, and uh, you will be familiar with it. I can, as the admin of the system, I can see how you are doing on your VR, and we can, I can guide you if you need any guidance, and we can be in contact through that platform. This is what I have in mind. But if you think of any other design for this class, which you think it might be better, please tell me, and we can do that. For
I mean,
example, one other option is in this class, during the class, we use the VR platform and practice the VR platform. This is one option without any lectures. Another option is we don't need this class. You can practice on your VR, and we are in contact through our Precision OS account, and we can uh, see how things are moving forward. So it's up to you. Tell me what is best for you.
I think personally for me is keeping the lecture and then having the VR outside of class just so it's like sort of doubling the knowledge. Like we learn about it and then we can actually see how it's applied in the surgery. So it's kind of like you're double learning from experience as well as the lecture.
I agree with
Okay,
that.
you agree.
I'm good
And
with
I'm good with that
me,
too.
you agree with that. Scarlett,
Mm.
you agree with that.
Yeah.
Okay, so we continue with the same structure. We for these classes, you don't need to be prepared to prepare your VR headset. Okay, in these sessions, continue with a short lecture about that surgery, and I introduce different aspects of that surgery to you and different aspects of that device, so you become familiar. And then we watch some videos, and during the week after this class, before the next class, you have time whenever you want. You have time to practice on your VR headset as many times as you want. Okay.
So, Professor,
And sorry.
so what are you like? What are you looking for in the VR? Like when you get our results, what are you kind of looking for to get like, I don't
Oh,
know, for like a
I
grade
just wanted
wise?
to tell that.
Okay.
Yes. Don't worry. Look, you are not surgeon.
that.
So I don't expect you to, when you are performing the surgery, because the scoring system in the platform is for surgeons. It is for them to learn how to perform the surgery correctly, how to put the first pin in the correct direction. Okay? It is not something intended for you. You must be familiar with the general concept of the surgery and the surgical environment, okay? Not the details of the surgical procedure. I just want to see you have performed the surgery and you have done all the steps, even if they are wrong. Don't worry. You can learn the correct one. It's good to have knowledge about something. It's not bad, but it is not my intention. If I see that first time you have put the pin in wrong direction, I say, okay, uh, uh, 1 minus. No, 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 no. That's not the case. I want you to become familiar with the general concept of the surgery, specifically the surgical environment, and the size of the incision, the field that you have to work in. For example, when you are performing a spine surgery, if you design a device that is 10 centimeter in 10 centimeter, you cannot use it because the spine incision is 5 centimeter. So if you know the size of the true surgical field, then when you are designing something, you know how to design. That is my intention.
Hmm.
My intention is not for you to learn the surgical procedure steps. That's something up to the surgeon, not up to you. But when you want to design something, you must know uh, where it is used, how it is used. And this VR system give you the concept of how it is used. That is the uh, goal of this VR. And the goal of the surgery videos that I show you, I don't want you to learn the steps of the surgery. I want you to become familiar how the surgery is done, in which uh, environment and in which uh, way it is done. Today we have a video. It is a long video of surgery of intramedullary nailing of femur. But I want to show you only a small part of it, a short part of it, about the inserting the guide and nail into the femur during the surgery. And I want you to see how difficult it is. So maybe in future you can, with having it in mind, you can change this problem. You can solve this problem in a way. Okay, so don't worry about if you are doing something on VR and it is wrong. It has no negative impact on your final score. Okay, don't worry. Okay, let's go back to our lecture. So today we are going to check the intramedullary nail, and in Precision OS app, it is called Sign IM nail. Okay, Sign IM nail. That is the intramedullary nail. As the name shows, intramedullary nail and by the way, today we have let me show my oh, my cat left. He was sitting here watching the class. We had a guest today. He just left. As the name shows, intramedullary nail is a rod that is inserted inside the medulla of long bones. The most common bones that are fixed with intramedullary nailing are femur, tibia, and humerus, but femur and tibia are much more commonly fixed with intramedullary nailing than humerus. And rarely we use them in bones of the forearm, long bones of the forearm. But we never use intramedullary nailing for short bones or irregular bones. We use intramedullary fixation for other bones. For example, in vertebra, when we put a screw, we put it intramedullary. Or in pelvis, we use some screws. I have an animation that I prepared myself for you. I will show you during the course one day about the pelvic fixation, how we fix the pelvic fractures. Pelvic is an irregular bone, but we use screws inside the medulla to fix the pelvis, but they are not called intramedullary rod. They are intramedullary screws. Rod is only used, or nail is only used in long bones, femur, tibia, humerus, and rarely radius and ulna in the forearm. These nails have different types, different shapes, and different functions. They are available for almost 100 years. And the first type was a simple straight rod, a solid rod, but gradually the shape changed and different shapes, different designs, different additives was added to them. We have nails can be simple nail, or we call them unlock nails, or they can be locking nails. They can be rimmed or unrimmed. They can be antegrade or retrograde. They can be solid or cannulated or elastic. And sometimes we have specific nails for specific applications that I will show you some of them. As general, they are a long rod that are inserted from one side of a long bone into the medullary cavity. They can be a simple rod, a simple pin, but a large pin, or they can be a complex structure, but both of them are inserted inside the medulla to fix the bone. They can have different lengths different diameters, and different cross sections. They can be curved or straight. You see, uh, our bones are usually curved. They are not completely straight. They have tibia, femur, and humerus. They have a slight curve along their length. So if we use a straight nail inside the medullary canal, we have some problems with aligning the fracture. That was the problem with the first designs of the intramedullary nail. So gradually they added a curvature to the nail. You see here, the nail is slightly curved. The curvature of femur is the periphery of a circle with a radius of 2 meters. So the radius of this curvature must be about 2 meters. The length of intramedullary nails can be completely different in different designs. For each design, we have different lengths based on that can be selected based on the length of the femur. For example, my femur may be 40 centimeters, but the femur of another person may be 48 centimeters in length. So we need different nails because the nail must be inserted must cover the whole intramedullary canal. But some nails are shorter because we don't need to cover the whole canal. For example, if the fracture is here, we don't need to pass the nail up to the distal part and fix it here. If we pass the nail about 2 or 3 inches past the fracture site, if the fracture site here, the length of nail is enough to be up to here. So that is why we have different types of nails, and the one that you will see in VR system is a short nail. When you insert it, it will not pass up to the distal end of the femur. The diameter of them is also variable. Some of them are very thick. Some of them are have smaller diameters. Why we need different diameters? Because the diameter of the intramedullary canal is different in different peoples. And when we insert a nail, we need to fill the medullary canal. The medullary canal is smallest in diameter in the middle part, in this area, in femur, and also in the middle part in tibia. So when we insert a nail, this nail must fill the medullary cavity, like here. When we insert a small diameter nail, this nail will be in contact with the cortical bone. When it fills the medullary cavity, it will be contacting the cortical bone in a small area. But if we use a larger diameter nail, it will be in contact with more cortical bone, and it gives the nail a better stability. We will discuss it later, how we get this contact. Some nails are solid, some nails are cannulated. Cannulated nails are the choice for today surgeries because we can reduce the fracture and insert a guide wire first. Guide wire is a small wire. We can pass it inside the medullary cavity. It opens the medullary cavity and we can check the reduction, and it doesn't harm and it doesn't injure any tissue in the medullary cavity. And then when we are sure, we can pass the nail over that guide wire. But solid nails, cannot be passed over the guide wire. So we have to insert the nail blindly, and sometimes it causes problem. Let's discuss some mathematics here. We have different concepts in nails because nails are rods, circular rods, and they behave like a circular rod. So we can discuss bending stiffness, bending stress, torsional stress, and axial strength. So let's see how the diameter of the nail has effect on these different parameters. All these parameters are important for us: bending stiffness, bending strength, torsional strength, and axial strength and stiffness. If they are higher, all of them, if they are higher, it means the nail is more rigid. So it will tolerate more load. And that is something that we want. Bending stiffness is the nail's resistance to bending. It is not the same as bending strength. Bending strength is something else. Bending resistance is the resistance, bending stiffness is the resistance to bending. It is calculated for circular cross-sections rod by this equation. So you see, it is related directly to the diameter. But there is a concept. The concept is called second moment of area, of area moment of inertia, of moment of inertia of an area. All of them are the same name of something, of one thing. Second moment of area is actually the geometrical property of a shape that shows you how the area is distributed among a central axis of a circular cross-section. Based on this second moment of area, you know that how the surface and the material is distributed around that axis, that central axis. So if they are distributed further, the moment of area, the second moment of area is higher. If they are distributed closer to the axis, the second moment of area is lower. So the second moment of area depends on the diameter. And since the bending stiffness is proportional to second moment of area, which is shown by I here, the bending stiffness is proportional to diameter, but to the fourth power of diameter. Now consider you have a nail with a diameter of 3 millimeters. The bending stiffness is proportional to the fourth power of the diameter. So the diameter is 3 millimeters, the fourth power is 81. But if you have another nail with a diameter of 4 millimeters, the fourth power of 4 is 16 by 16. What is 16 by 16? It's 256. By increasing 1 millimeter in diameter, the bending stiffness changed from 81 to proportion of the bending stiffness changed from 81 to 256. And if you increase the nail diameter to 5, it will be much higher, and so on. That is why we want to use larger diameter nails as much as possible, not the largest nail. You will see later we have some limitations. But if we can use with considering those limitations, if we can use a larger diameter, it gives us a better bending stiffness. And this proportion is the one that allows us to use a cannulated nail, a nail with the hollow central part, because when you make the central part hollow, actually you are removing some part of the material, but still you have enough material. For example, consider you have a 4 millimeter nail. The S bending stiffness, if it is solid, is proportional to 256. If you remove 3 millimeters of the material inside it, if you remove a rod with 3 millimeter diameter from inside this and make it a hollow rod, you remove 3 millimeters, so you removed 81 distribution of the material from inside. So the material that is remaining still has 256 minus 81. Still, it is a high proportion for bending stiffness. This equation allows you to make the rods that are used in buildings, in the cars. For example, the rod that is used for the axles in the car, they are hollow. The center of these rods are empty, because they can remove the center and still the material is stiff enough to tolerate the bending and torsional force because of this relationship and proportion to the fourth power of diameter. Bending strength is the ability of the nail to resist bending failure. It means the ability to resist failure. The bending stiffness was the ability to resist bending, any amount of bending. But when the bending is severe and the nail wants to fail, the ability to resist this failure is called bending strength. And it is proportional to third power of diameter. It is proportional to something called section modulus, which is calculated like this with this equation. And bending strength is proportional to section modulus. So it is proportional to the third power of diameter. What is section modulus? It is an engineering, a geometric property that shows you the relationship between the moment of inertia and the distance that this inertia is applied from the central axis. So it shows you the distance from the central axis, from the point that the inertia is applied, and the amount of this inertia. So the relationship between distance and the amount of inertia is called section modulus, and it is proportional to the third power of diameter. And this section modulus is proportional to bending strength. So the higher section modulus, the higher bending strength. It means the higher the diameter, the higher the bending strength, the higher the resistance against failure, bending failure. But it is not as strong as the bending stiffness because it is proportional to the third power. Bending stiffness was proportional to the fourth power. Torsional stiffness, resistance against any torsional movement. Again, it is proportional to the polar moment of inertia. Polar moment of inertia is, again, a geometric property. It represents the resistance to torsion about an axis perpendicular to the cross section. Perpendicular to cross section means the central axis. The central axis in the middle. When we have a torsion around that central axis, the polar moment of inertia shows the resistance against that torsion. So again, this polar moment of inertia is proportional to the fourth power of diameter. And since torsional stiffness is proportional to the polar moment of inertia, it is also proportional to the fourth power of diameter. Again, it means that the larger diameter gives you a better resistance to torsion. And since it is proportional to the fourth power, a slight increase in the diameter increases the torsional stiffness significantly. And the last one is axial strength, which means the ability to resist or withstand compression or tension forces. This property is proportional to the second power of diameter. It is proportional to the cross-section area or the surface area, which is calculated by the second power of diameter. So increase in diameter of the nail also increases axial strength, but not as much as the other parameters. So these four parameters shows us that if we want to have a stable fixation in intramedullary nailing, we need to have a larger diameter nail. But how much large? How large we can use it? Let's see. First, let's discuss the cross section. The first nail that was introduced was solid circular. The light blue is bone, and the darker blue is the nail inside the medulla, okay? And you see during the several years, different nail shapes has been introduced. And each one of them had a specific use, or they had some advantages and disadvantages, and after a while they were abandoned. And here you see different nails. They are all cannulated. They are inside them are empty, and you see some of them are straight, Some of them, like this one, it has the same shape. These are called clover leaf uh, nails. The cross section is like a clover leaf. Some of them are circular. Currently, most nails are circular because we use a concept called interlocking screws, and we don't need different cross section to increase the rigidity, torsional rigidity, or bending rigidity. We use locking screws, and that replaces all these benefits that we gain by the different cross section. Cylindrical cross section is the best one for now because it is easy to insert. It provides good bending stiffness, torsional stiffness, and good fitness when we insert it. And the good thing with cylindrical or circular cross section is the bending stiffness and torsional stiffness are the same in all directions because they are the cross section is circular and it is the same. It has the same shape in all directions, so all the bending and torsional stiffness are the same in all directions. We have triangular and square cross sections. Some of them are still in use for specific uses, especially in nails that we want to have a special use for them, like lengthening. Sometimes we don't use, we use the nails in normal bones, and we perform an osteotomy and gradually increase the length of that osteotomy. So we can increase the length of the bone, and in this way we can increase the height of the person. But these nails should have an internal structure that allows this lengthening. So they need to add some additional factors to keep their stability. So these triangular square shapes are now used in those nails, not for fracture fixation. But for fracture fixation, we don't need these triangular or square uh, nails because their insertion is difficult. They have sharp edges. These sharp edges are stress risers, so they can create stress risers in the bones and they can cause fractures. And also, during the insertion, these sharp edges may damage the bone while we are inserting them because they cannot slide over the bone. They can scratch the bone and go in and damage the bone. But they have something good. When they are wedged inside the bone, they offer good torsional stiffness because they hold the bone and they don't allow the bone to rotate around them. But when the cross section is circular, the bone can rotate around the circular nail and the torsional stiffness is not as much as these square or triangular one. Some of the nails can be elliptical or a flattened circle. They are good. Sometimes they feel because the medulla of the long bones inherently is not circular unless we perform rimming inside it. We drill inside it. Otherwise, it is not a perfect circle. So sometimes using the elliptical nails theoretically fills the medullary canal better. But Sometimes they are very difficult to insert, and since the diameter in different directions are not the same, their bending and torsional stiffness are not the same in all directions. So they may fail easier in one direction than the other, and it is not something that we want. So due to these reasons, almost all the nails that we currently use are circular in cross section. Sometimes the nails can be grooved like this, or can have flutes on it. And like the triangular nails, these flutes can be inserted inside the cortical bone, and it can hold the bone rigidly, and they create a good torsional stiffness for the bone nail structure. Just to clear something, I was discussing here the torsional stiffness and the diameter and the proportion between these two. This is the torsional stiffness of the nail, okay? When here I was discussing the triangular and square cross sections, like this or like this. I said they wedge inside the bone and increase the torsional stiffness. This torsional stiffness has nothing to do with the torsional stiffness of the nail. It is the torsional stiffness of the bone and the nail around the nail, not the nail itself. I mean, the bone can rotate around the nail if it is circular, but if it is triangular, the bone cannot rotate around the nail. Okay? So these two are two different things. The flutes here increase the rotational stability of the bone around the nail, not the nail itself. The nail itself, the rotational stiffness of the nail depends on the diameter, okay? It has nothing to do with these flutes. But these flutes hold the bone around itself and doesn't allow the bone to rotate easily around the nail. So the bone nail construction altogether become more rotationally stable. Said previous and early designs of the nails were solid, but currently they are cannulated, and it has many benefits. It gives you a lighter nail, so a rigid nail with will be heavy, but it is lighter, and also it is more flexible. And you remember from the plating, when we have a more flexible fixation, we have more strain in the fracture site, so we have a better secondary bone healing. So everything is in favor of the cannulated screw. Insertion is easier. We can first put a guide wire. With a wire, we can check everything. And when we are sure, we insert the nail. So everything is better with cannulated nails, but sometimes we need these solid nails. These solid nails are stronger, a little bit stronger, not too much, but sometimes we need them for two reasons. One, we may need a very solid and rigid nail because the fracture is comminuted and there are lots of fragments in the fracture size, and we need a rigid nail to hold the bones there. And the second one is sometimes we need a very fast surgery. If we use cannulated nail, you will see first we have to put a guide wire, and then perform rimming, and then change the guide wire, insert another one, and then insert the nail. And it takes about 1 hour. But if we use the solid nail, we open the medullary canal and insert the nail, and it takes 5 minutes. In good hands, not in any hands. In good hands, it takes 5 minutes. So sometimes to save the patient's life, we need to use a solid nail. That is why they are still in use. A concept that was added to the nails several years ago, and they are still in use, and they are a perfect concept, is locking nail. But we don't call it locking, we call it interlocking, because we lock the bone, nail, bone. Nail is in the middle of the, like a sandwich, it is in the middle of the bone, and the screw passes through the bone, one cortex, through the nail, and through the other cortex. So the nail is interlocked inside the bone. These screws are put through the nail on two sides of the fracture side. And when you fix the nail in these, with these screws on two sides of the fracture side, actually you are fixing the length of the fixation, because the bone cannot move here and it cannot move here, and the lengths remain fixed. It has nothing to do with the bending and torsional stiffness. It only increases the axial stiffness and holds the length. Sometimes, if the fracture is very oblique or it is a spiral, and if you leave the fracture, it will twist around each other, and there will be shortening between the in the fracture site. Or sometimes there are many fragments here, and if you leave the nail here without interlocking, it gradually slides and there will be shortening. But based on the original length, we lock the nail and it doesn't allow any shortening here. And actually it revolutionized the interlocking, the intramedullary nailing. The locking mechanisms are the screws, but sometimes you will, I will show you some new designs. Instead of a screw, they use nails, or they use very large screws. But whatever they are, they do the job the same as the screws. They can be static or dynamic. What's the difference? When you put the screws through the bone into the nail and then through the opposite cortex, these screws on both sides of the fracture sides locks the nail to the bone. So there will be no shortening because they are rigid. And as long as the screws are not failed, they remain in place and hold the length. This is called a static locking. The length is fixed. But sometimes we need a little bit compression in the fracture site. For example, when we have a transverse fracture with a few comminution or a few number of fragments here, and we are not worried about the shortening, we can use some compression here while the patient is walking. But the static locking prevents this because it doesn't move. So we have two options. It depends on the design of the nail. Some nails have a dynamic hole. One of the holes is the size of the locking holes in the nail are the size of the outer diameter of the screw. So the screw can pass easily through it, but cannot move inside it. But they have another hole that is called dynamic hole. It is larger, and when you put the screw away from the fracture site, the fracture site is here, okay? The screw is away from the fracture site. When you apply load, the nail moves upward, but it is not too much, just as the length of this hole allows. And it causes compression, a little bit compression in the fracture site. And this is called dynamic screw. Let me show you if I have. You see here, this is an static hole. In the distal, you have two static holes, but the upper part, you have one dynamic hole. This is the dynamic hole. If you put the screw away from the fracture site while the patient is walking, the fracture site will be compressed. So when you want to use the dynamic screw, you should not use the static screw on the same side. Only we use the static screws on the other side. We interlock or lock the screws on the other side of the fracture, but on the same side of the fracture side, we don't use the static screw, only the dynamic screw, if we want to have dynamic locking. But we have another option. The other option is not using the screws on one side at all, only using on one side. This is less stable, but this is another option, having a dynamic locking. There are many benefits. We discussed the benefits. They secure the bone to the nail, so the length is almost fixed. In fractures that we want to prevent the bone from collapsing, they are very useful. So they prevent shortening, and these locking screws, because they pass through the bone. And when we use the interlocking, we don't use the largest diameter possible. We try to use one size smaller to allow the rotational and compression movement, so we can have load sharing instead of load bearing in the nail. And you remember, when we have load sharing between a fixation device and the bone, this is the ideal situation for us, because some part of the load is transferred through the fixation device, some part of it is transferred through the bone. And this part that is transferred through the bone helps the bone to remodel itself, because the bone needs to be under load to keep its content. We discussed yesterday. So if we have a load bearing device, if it is a plate, intramedullary nailing, or an implant, it is not good for us. We always try to use a load sharing device. And that is a beauty for locking, interlocking nails. And they are, as I said, they are used for different applications. But one important concept rimming or non-rimming. What is rimming first? Rimming is a type of drilling, but instead of a classic drilling, we use a specific drill head, which is flexible, and it is used for inside a cavity, inside something. For example, you have prepared, you drilled a hole in the bone, but you want a perfect finish inside this hole. Then you use a reamer, which has a different design than drill. And this reamer will increase the finish inside the hole. We use the same concept for intramedullary area. We use a flexible reamer and we try to make a perfect finish inside as a cylinder inside the medullary cavity, which fits with the intramedullary nail. After rimming, we have a cylindrical cavity inside the medullary, and now we can insert the intramedullary nail easily inside that cavity. But why we use it is inserting the nail easily is our only goal? No. This is a reamer, and this is the reamer head. One of the goals is to create a larger diameter, to create a cavity inside the medullary canal with a larger diameter. If we don't rim, the narrowest part of the canal determines the diameter of the nail. But when we rim it and we remove some part of the inside the medullary canal and maybe some part of the cortical bone, it creates a larger diameter. So we can insert a larger diameter nail with all the benefits we discussed: bending stiffness, bending stress, strength, torsional strength, and axial stiffness. And also the contact between the bone and the area of the contact between the bone inside the medullary cavity and the nail increases. With rimming, it will be only a few millimeters, but without rimming. With rimming, it will be increased to several centimeters, and it increases the torsional stiffness of the bone-nail construct. So this is the benefit of rimming. It also, when we are rimming, we are actually increasing the blood flow in all limb. It is another benefit, but it has several drawbacks. I said there are some limitations. The first one is when we are rimming, we are destroying all the cancellous bone in the medulla. This is one drawback. The second one is when we are destroying the cancellous bone, we are destroying the blood supply to the medulla and the inner cortical bone, the inner layer of the cortical bone, because the inner layer receives its blood from the medulla. When we destroy this blood supply here, we endanger the inner layer of the cortical bone. And since it is a reamer and this area is thick cortical bone and it is very strong, when we want to rim it, it creates heat. And this heat, because it is a closed space, this heat accumulates here and may cause thermal necrosis, and the cells around it may die. That is why when we are performing the reaming, we have a limitation. We cannot ream as much as we want. When we reach the cortical bone, we can increase the ream size one size above. We can, for example, we start with the reamer size 7, we increase it to size maybe with 0.5 millimeter or 1 millimeter. It depends on the surgery and the surgeon preference. But 7, 7.5, 8, 8.5. When we reach 8.5, we are feeling that we are reaming the first part of the cortical bone. It means we have reached here. So we can increase one to the next size, and that's it. So 7, 7.5, 8, 8.5. 8.5 was the first reamer that touched the cortical bone. 9 is the largest diameter. We cannot pass 9, because if we ream with 9.5, we are reaming a lot of cortical bone and we are creating a huge amount of heat here, and it will cause thermal necrosis, and the bone here will die, and it will destroy everything we have done. So reaming is what we want, and today, most of the time, when we can, we use reaming, but it has limitations. Sometimes, for example, if the patient has had a previous surgery, or the patient had a severe trauma to the limb and the muscles around the femur or around the tibia are severely injured, so the external blood circulation to the bone is damaged. If we perform reaming, we are also damaging the internal blood supply. So in this specific patient, external blood supply and internal blood supply will be damaged, and the tibia or femur will die. So if we have a severe trauma to the limb, we do not use reaming. We use unreamed nails. We know that they are not perfect for fixation, but saving the patient bone and life and limb is more important than performing a biomechanically sound fixation. We must balance everything. So in the VR that you will see, you perform reaming, and reaming is one step in your surgery. Another conditions that we don't use reaming is when we want to use solid nails. For solid nails, we don't need reaming. We insert the nails directly because we use smaller diameter nails. And as I said, they are when we need to decrease the length of the surgery. The patient is critical and we have to fix the bone but in the shortest time. So we do not use reaming in those conditions. Here comes a conflict here. We have a complication. This is just for your information, okay? This is not in the slides. I'm explaining it just for you to be familiar with this complication. This is a clinical complication called fat embolism. Inside the medullary canal, specifically in femur, is filled in the middle part, is filled with fat tissue. This is called white marrow, white bone marrow, in contrast to red bone marrow that is inside the cancellous bone. So in the middle part, we have a few trabecula of cancellous bone, and the rest is fat. This is the same fat that is inside the bone that you cook and you eat that fat. You are familiar with the fat inside the bone. When you cook it and you break the bone, there is a fat inside it. This is the same thing. So when we insert anything inside this bone, specifically in femur, we compress this fat because this is a closed space. So we compress this fat, and this fat can escape into the blood and goes to brain. And when it goes to brain and to lungs, it causes some problems called fat embolism. And it is very dangerous. It can cause altered consciousness and sometimes even coma. When we are performing rimming, actually the rimmer disrupt this fat without increasing the pressure. But when we insert the nail without rimming, we are pushing the nail over this fat, and we are increasing the pressure on this fat, and we increase the risk for fat embolism. This is a clinical reason why the surgeons prefer to use rimming, even if they want to use a small diameter nail. It has no biomechanical effect. It has a clinical effect because the rimmer has sharp edges and it breaks and tears the fat tissue inside the medulla, and it has no time to be under compression with the with rimming. But with nail, when the nail is inserted directly into the medulla without rimming, it increases the risk of fat embolism. So this is a major reason why the surgeons prefer rimming. And we discussed the property of load sharing and load bearing. I don't want to discuss it. Just, and the nails, when we use them, they are under repetitive compression and bending, and they must resist this. So they must have very acceptable fatigue resistance and also durability against the corrosions. So they will not fail with repeating loads on them. This is something related to their material and their production process and how we insert them. While we are inserting the nail, we must be careful about damaging the nail. If we insert a screw by mistake in the wrong direction and it damages the nail may fail easily. So we must be careful when we are performing the surgery. We discussed the stress shielding. These are different types of the nail, not all of them, but you can see how different they are. This is a classic long nails that passes through the intramedullary from proximal to distal. We call it antegrade because it goes from proximal to distal. We may have the same nail, but in reverse, it is called retrograde because it goes from distal to proximal. It goes, the surgeon must open the knee joint and insert it through the knee joint. Why we use it? Because sometimes we have a fracture site very close to the knee. So from this side, we cannot fix it. And also sometimes we have another device here For example, patient has a previous implant here. We cannot insert a nail beside the implant. Implant has filled the cavity. So we insert a short retrograde nail here to fix the fracture. You see here, it is a proximal femoral nail. In contrast to this long nail, it is very short. It is used for the fractures around the hip in this area. The screws can have different shapes. They can be in different directions. And you see in the proximal part, instead of these two parallel locking screws, you can have a nail going into the femoral head, or you can have screws. So these are some examples of the different nails in the femur, but we have the same variety for tibia, for humerus, and there are countless, really countless. I cannot include all of them in the slides. Any company has several types of the nails and screws. For example, here we discussed the dynamic holes. You see, this one is a static one, but this one can be a dynamic one. It's a long hole. Or here you see, this is a static one. This is a dynamic one. When we use both of them, it will be a static locking. But if we remove this one and only use this one, this screw, it will be a dynamic locking. You see it here. So these are different types. Now let's see a classic. Any question before watching the video? No?
Yeah, I have one, Professor.
Yes.
So you said there's like loads of orientations and I guess lengths or thickness of the screws. Is there like certain ones that you use for certain surgeries, or is it up to the preference of the surgeon?
Based on the usually there are many factors. Classically, the type of the fracture and the demand of the patients are the most important factors. But in practicality, you must have, based on these two, you select a nail, biomechanically perfect. But in practice, you must have that nail in your hospital. The patient must be able to pay for it. So there are several factors. Sometimes you have to change it. For example, you don't have the specific nail you want, you have to use another one that is not perfect, but it's acceptable. But yes, classically, we select the nail based on the fracture pattern and the patient demands, which considers the biomechanical properties of the nail. This is the way we select the nail.
When I wake up in the morning, I feel good. By the end of the evening, I'm in pain, bad pain.
Intramedullary nailing with the expert tibial nail with reaming. The expert tibial nail has a new anatomic bend that makes nail insertion and extraction easier. The cannulated version enables nail insertion over a guide wire. There are several possibilities for proximal locking. 3 of these locking options use cancellous bone locking screws to improve stabilization of the proximal fragment. The 2 mediolateral locking options enable primary compression or secondary controlled dynamization. There are 4 possibilities for distal locking. One oblique locking option is very distal. It allows two different interlocking directions for ideal bone purchase and prevents damage to soft tissues. There are two mediolateral options and one antero-posterior locking option for stable fixation of the distal fragment. The expert tibial nail is indicated for fractures in the tibial shaft, as well as for metaphyseal and certain intra-articular fractures of both the tibial head and the pilon. These fractures are 4-1, A2, and A3. 4-1, C1 tibial nail. With or without tibial nail can be inserted tibial nail. The expert tibial nail can be inserted into the medullary canal either with or without reaming. In this presentation, reaming will be demonstrated. The nail will be inserted over the guide wire. Shaft fractures will be introduced. With simple shaft fractures, 4 mediolateral locking screws are normally sufficient, 2 distal and 2 proximal. Secondary dynamization is achieved by removing the locking screw from the static locking option. In very proximal and distal fractures, additional interlocking is required. The patient is placed in a supine position on the radiolucent table. The knee of the injured leg has to be able to be flexed at least 90 degrees to 100 degrees. The image intensifier is positioned so that visualization of the tibia, including both the proximal and distal articular surfaces, is possible in the AP and lateral views. A leg holder may be used to help for reduction, surgical approach, and insertion of the nail. The knee roller has always to be placed under the lower thigh to avoid neurovascular compromise in the popliteal fossa. The closed reduction is performed manually using axial traction under image intensification. The reduction can be temporarily fixed with reduction clamps. The required nail length must be determined after reduction of the fracture. The image intensifier is positioned for an AP or lateral X-ray of the proximal tibia. Using long forceps, the radiographic ruler is held parallel to the tibia on the lateral side of the lower leg. The ruler is placed so that its distal end is level with the required nail insertion point. The skin is marked on the lateral side. The image intensifier is moved towards the distal end of the tibia. The proximal end of the radiographic ruler is aligned with the skin marking, and an X-ray of the distal tibia is taken. The reduction is verified, and the required nail length is read from the radiographic ruler as it appears in the X-ray. The image intensifier and radiographic ruler are also.
When I wake up in the morning, I feel good. By the end of the evening, I'm in pain, bad pain.
Used to.
I'm sorry, I don't know why these advertisements are here, because I have a YouTube premium account and there must be no advertisement where I use them. Maybe they are from the original YouTube page. I don't know, but I'm so sorry, they appear here.
Establish the appropriate diameter of the nail. The entry point is decisive for the position of the expert tibial nail in the medullary canal. This position is most important for correct fragment alignment of proximal and distal metaphyseal fractures. In the AP view, the entry point is in line with the axis of the medullary canal and with the lateral tubercle of the intercondylar eminence. In the lateral view, the entry point is at the ventral edge of the tibial plateau and in line with the medullary canal. The guide wire is secured in the universal chuck with T-handle. At a 10-degree angle to the shaft axis in the lateral view, the insertion point is lightly punch-marked. The guide wire is advanced approximately 8 to 10 centimeters. Its position is checked with the image intensifier in the AP and lateral views. The protection sleeve and the cutter are inserted over the guide wire, and the medullary canal is opened to a depth of 8 to 10 centimeters. The guide wire and the cutter should not touch the posterior cortex. The guide wire, cutter, and protection sleeve are removed. As an alternative, the cannulated drill bit or the cannulated awl may be used. If necessary, the medullary canal is enlarged to the required diameter with the medullary reamer. In a clinical situation, passage through the fracture zone and the correct position of the reaming rod are verified with the image intensifier. Depending on the diameter of the nail, the appropriate diameter reamer heads are selected. In this case, the nail diameter is 9 millimeters, so reamer heads from 8.5 to 10 millimeters will be used. The reamer head is mounted on the flexible shaft. The holding forceps is used to control the position of the reaming rod. The reaming rod is inserted into the medullary canal. The reamer head is advanced with gentle back and forth movements. Force must not be used. The medullary canal is reamed in 0.5 millimeter increments until the diameter of the canal is 0.5 to 1.5 millimeters larger than the nail diameter. The insertion handle is directed anteriorly, and the tongue of the handle is matched to the notch in the nail. The connecting screw is placed through the insertion handle and is threaded into the nail using the hexagonal screwdriver with spherical head. With the insertion handle, the nail is introduced into the medullary canal. Slight rotational movements can help the insertion. The passage of the nail across the fracture is monitored with the image intensifier in 2 planes to avoid malalignment and additional iatrogenic fractures. If necessary, light hammer blows may be used. The connector is secured to the insertion handle. The hammer is used in the fixed mode. If more insertion force is necessary, the hammer guide is attached to the connector, and the hammer is used in the sliding mode. The final
When I wake up in the morning, I feel good. By the end of the evening, I'm in pain, bad pain.
position of the nail is verified in the AP and lateral views, with the guide wire placed in the aiming arm as shown here. The insertion handle is marked in 5 millimeter increments, which correspond to the extensions of the end caps. This feature can be used for over-insertion of the nail or for correcting the nail length. If primary compression or secondary dynamization is planned, it's recommended to over-insert the nail up to 7 millimeters, which corresponds to the maximum distance between the positions in static and dynamic modes. Although distal locking will not be done in this exercise, it is briefly introduced here. The final nail position is checked with the image intensifier in the AP and lateral views. The steps shown are similar for proximal interlocking and will be explained later. Either 4.0 or 5.0 millimeter locking screws are used, depending on the nail diameter. Distal locking should be carried out first, so that the compression mode of the nail or the backstrike technique can be used to treat diastasis. The nail must have been inserted to a sufficient depth beforehand. The nail is usually locked from the medial side, with the leg extended if possible. The aiming arm can be used for different proximal locking options. These locking options are color-coded on the aiming arm and the corresponding instruments. 3 locking options, color-coded yellow, are combined with cancellous bone locking screws for ideal stabilization of the proximal fragment. 2 mediolateral locking options, color-coded blue and green, enable primary compression, secondary controlled dynamization, or static mediolateral proximal locking. In this exercise, static mediolateral proximal locking is demonstrated. As alternatives, dynamic proximal locking and oblique proximal locking will also be introduced. The aiming arm is attached, and a 3.2 mm guide wire inserted, as shown here. The tip of the guide wire indicates the exact proximal position of the nail in a mediolateral view. The 3-part trocar combination, consisting of the corresponding protection sleeve, drill sleeve, and trocar, is inserted through the mediolateral hole in the aiming arm. The trocar is inserted down to the bone through a stab incision and is then removed. Using the corresponding drill bit, both cortices are drilled until the tip of the drill bit just breaks through the far cortex. The drill sleeve is pressed firmly against the near cortex, and the measurement is read from the calibrated drill bit. This measurement corresponds to the appropriate length of the locking screw. The drill bit and the drill sleeve are removed. As an alternative, the length of the screw can be read from the depth gauge for locking screws. The measurement is read from the shaft of the depth gauge. It corresponds to the appropriate length of the locking screw. A locking screw is inserted with the star drive screwdriver through the protection sleeve until the head of the locking screw lies against the near cortex. The tip of the
You see how the nail is inserted on a saw bone and the different devices we use for inserting the screws. This is one type of the device. Let's see another one.
the locking screw.
Briefly.
When I wake up in the morning,
So we have to watch it on YouTube.
Negotiate the C arm and trying to bring the intramedullary. So in terms of theater setup and patient positioning, our trolley will be on this side. Our C arm will come from the opposite side. Our screen
the real
will be in the front so that we can see the screen easily. For positioning, I like to do my tibia nail in this particular position in which the leg is on the table. I know there are a lot of surgeons who do leg hanging. I don't like that because I feel sterility is a big issue when you hang the leg. So I don't have access to a specialized leg holding device, but this is an anesthetic screen and you can use it. I've used it and I've padded it so that leg is roughly around 90 degrees, and I find doing nailing in this much more easier, and I'm confident that I will be able to keep using the standard water impervious drain. I would recommend you to use this plastic sheet. So this is our drapery complete, and this is how it looks after on making my incision here. I always like to check with my C-arm to see whether my entry point is perfect or not. So to mark our entry point, I have just used a Steinman pin and I checked it with the C-arm in order to make sure that entry point is perfect. So our starting entry point is just medial to lateral tibial spine. So I'll show you how this guide wire looked when I took it under C-arm. So if you look at the C-arm pictures, our Steinman pin is just medial to lateral tibial spine, and this is pretty perfect on an AP view. So as you can see, our incision is not pretty much central in the patellar tendon. because your skin marking can be erroneous. So I always suggest that use a streamline pin to mark your entry point and then make your skin incision. So there are two ways of doing your entry point, whether you can go medial to the tendon and don't disturb the patella, or you can go transpatellar. So today I'm going to go transpatellar. So my skin incision is just from tibial tuberosity to the bottom of the patella. So just stay in line and keep going straight.
This is what I want you to keep in mind. All those devices, all those pins and nails must be inserted through this small incision. So they must be designed in a way that they can be inserted through this incision without injuring the tissues here.
So you have taken the skin down, you have taken the subcutaneous fat down, staying in the same midline. You're just going to stay in the midline. And the first structure that you will find is, paratinon. So we're just going to divide the paratinon, which is a covering of the patellar tendon. So I'm just going to stay in the same line. And as you can see now, I'm dividing the paratinon, and you can start seeing the tendon coming up. And I'll respect this paratinon as a thick layer, and I'll show you how it looks. It's a pretty thick layer, you can't miss it. So this is the medial border of paratinon, so just going to lift like that, and this is the lateral border of paratinon. And the shiny structure that now you see here is your patellar tendon. So next I'm going to be in the straight and then divide the patellar tendon. Just go in one straight line. Just be very, very careful when you are dissecting close to tibial tuberosity, because you don't want to be damaging the meniscus. The anterior horn is pretty close. So just stay in the same line, and then we'll replace the retractor. So I have retracted the patellar tendon, and then the structure that you see is the Hoffa fat pad. And just below the Hoffa fat pad is the flat surface of the tibia where our entry point will be, and I'll show you in a diagram. So on AP view, as I have said, our entry point is just medial to the lateral tibial spine. On lateral view, you see this is the femur, this is the tibia, this is meniscus, this is the fat pad that I have shown you. Now you see there is a flat surface here. I try to make my entry point on this flat surface. I don't try to enter here, because the attachment of anterior horn of both medial and lateral meniscus are pretty close. So you can make a small hole, but once you start reaming, you have very good chance that you will damage the meniscus. So always aim to start here and then try to be parallel to the tibial cortex. So I have checked my entry point on AP. Looks pretty good. Just lateral, bang in the center here. Here on lateral, I talked about the slope. I try to be below this corner because I'm worried about meniscus. So this is a good entry point. All I need is to lift my all up so that this becomes parallel to the anterior tibial cortex. So all I'm doing is pressing it down and just gentle hammer, and then I will check on the CM. And as you can see, the all is going almost parallel to the anterior tibial cortex, and also it is away from the articular margin and from the meniscus attachment, especially the anterior horn of both meniscus. So now checking my all position after burying it a bit deep, both on AP and lateral looks pretty good to me. You can use all, or you can use a threaded pin to make your entry point. If you're using a threaded pin, then you can use a cannulated awl on top if you have got access to cannulated awl. I find using awl much easier, and I find it much more controlled, but that's my personal preference. The next step is removal of awl, and then starting with this perforator or starting reamer. So make sure that you're ready with your perforator or your starting reamer when the other person is taking out. This way you don't lose the hole. So now we have passed our starting reamer, and it looks pretty good on AP. On lateral, in AP it's slightly lateral, it's okay. Usually when you look at the lateral, this will always go touch posterior. So this is how your guide wire will traverse. It will hit the posterior cortex, and then it will follow the medullary cavity, and I'll show you how it does. So next step will be just take this out and then replace it with our guide wire. So just put it in the same hole. So this is what I meant, that your starting reamer will go like this, but when you put your guide wire, keep the curve front so that it will hit this cortex and it will bounce back in the center of the medullary cavity, and then you're ready to proceed to put it down distally past the fracture site. So now we are ready to push our guide wire deeper into the distal fracture. Now passing the guide wire in tibia is, I think, perhaps one of the easiest thing if you follow the technique correctly. So you can see there is deformity. All I'm going to do is to just give some traction and keep this leg in the rotation that you are aiming for, and then I'm just going to keep this reduced while my assistant will pass the guide wire. So all I did was to give some traction and reduce the fracture, and we checked the lateral. You can see from here that the guide wire has nicely negotiated into the distal fragment. So one key message is, when you are passing, your assistant is passing the guide wire, what I see.
Let's see the reaming process.
I have put the self-retainer, I have put the tissue protector. One key point is, don't start reaming when the reamer is outside. So push it in. Now you can see the reamer is gone inside the bone. Then you start reaming. Otherwise what happens is, if your retractor comes off and the patellar tendon is very close, all this does is it damages the patellar tendon. So bury the reamer and then start reaming. So the key of reaming is, the reaming should be at the maximal speed. As with passing the guide wire, it's extremely important that I am keeping the fracture reduced, and I'm applying the forces to keep the fracture reduced. And you have to do the reaming when you have reduced the fracture. So you just can't put the guide wire and then start reaming. So hold the bones in the correct position and then start reaming. And ream with full speed. So once you have put the guide wire in the correct position, it is absolutely essential that you make sure that guide wire is not backing off. If your guide wire backs off, then all the good work that you have done becomes undone. So protect the guide wire as if you're protecting your life. So what we are using is, we are using a guide wire holder. So this will keep pushing in while we will withdraw the reamer, so that the guide wire doesn't come out. So now our guide wire is gone inside. So what I do is, I use something like a drill and then keep backing it out so that I am protecting my guide wire inside. And now, as you can see, so now you can see that my assistant can now see the guide wire, and now I can safely take this out, ensuring that my guide wire will not be backing off. And so we'll repeat the same exercise. Tissue protector in, I'm going to bury my reamer, and then only I'm going to start reaming, and my assistant will keep this in reduced position. So go with one constant speed. Go with one constant speed. One important thing I forgot to.
So you see the reaming process. Let me bring the here he's measuring the length of the nail, appropriate nail with the fluoroscopy. And now
Assembled. Always check when your scrub nurse gives you the nail that is assembled correct. This will be on the medial side. So we are doing this right leg. So this will be on the medial side. If you do this way, that is wrong way down. You can see there is a 10-degree curve, which Herzog's curve. This should be angled posteriorly. So this is the right way of putting the nail. If you do it this way, upside down, that is the wrong way. So once you're happy with the nail assembly, always check that the drill is going through the holes and which hole we are going to use. So on this occasion, on this nail, we are going to use number 1 and number 2 holes. So now we have just put the nail over the guide wire, and then I'm slowly going to use manual force to put it as much in as possible, and once it has stopped, I'm going to use mallet to gently put it to place. So now I'm just going to mallet gently. So never mallet here. I've seen people malleting here. You can see this check that you will not see any mallet mark here, because if you mallet here, the alignment between the mallet gets disturbed, and then there will be mismatch between the holes of the nail. So mallet here. So just gentle tap. Give some time for bone to breathe, and then just tap again. So even when you are malleting, just take few x-rays to make sure that you are heading in the right direction. At this point of time, our nail is at the distal end of the proximal part of the fracture. So key again is that our assistant, which on this occasion Dr. Kushwant, is going to keep everything reduced while we are tapping the nail slowly. So now you can see our nail has passed on to the distal fragment and the fracture seems to be nicely reduced. So we are going to proceed with the tapping till the nail has gone deep enough till we desire. So I'm looking at on the right side, I'm looking at the AP of the knee and incision, and then use the knife.
Again, here you see this device is larger than this area of incision. So we must be careful with the pressure on the skin here, because there is a bone beneath this skin and they may be damaged. This is one of the things that is important in considering designing these devices. Let me show you another video.
Rashid is showing you this mark we have. I would getting the right end.
This is an intramedullary nailing of femur. Okay, let's see how difficult it is done because of the tightness of the space that the
entry point. If your entry point is incorrect, then there is a very good chance you will struggle throughout the operation. Now there are two concepts of nailing, whether it was a trochanteric anterior of the shaft of femur. So when you are tapping,
this is the pelvis, this is the pelvis, this is abdomen, and this handle is pushing over the flank of the patient. And you see the skin is under tension here. The femoral bone starts here and ends on the other side. So you see, it's very difficult. And while you are doing the femoral nail in VR, you will see the same thing, but since you are in the VR, you can push this handle inside the body and nothing happens. But in reality, you cannot do that. And you cannot, in VR, you cannot feel this tightness. But here you see how the surgeon is performing.
I would,
watch this,
rather than twisting with the hand, I would advise you that use a mallet and go slowly with a hammer. Because this way it is more controlled and inevitably you will be in the right direction. So I said before, don't twist it. Use a hammer and mallet it. This way you will have much better control. And this is looking very nice. It's whenever ample time for this. When you are so checking again to the shed wire in the distance up to the fracture site. So when your assistant was reducing the fracture, the person on the top was pushing the guide wire, and on this occasion he felt the guide wire going through the distal aspect of the femur. So we're just going to check it on C-arm to see whether that is correct or not. So now checking the position in C-arm, it looks pretty good on AP and it looks pretty good on lateral, so our guide wire is through the distal fragment. So, and it can get broken. So while reaming, you can cause a lot of damage to the skin. So you have this beautiful instrument which is a tissue protector, and you should always put it on while reaming so that you don't do any damage to the surrounding skin. So it's a common problem that when you are reaming, the guide wire can dislodge, and for you to have a feedback whether the guide wire has changed position or not, one useful tip is that once the guide wire is in the right position, put a vertical mark with an ink on your drapes, as you can see. So Dr. Rashid is going to show you. Dr. Rashid is showing you this mark we have put. So if your guide wire is dislodging, never go halfway. So use the reamer on full strength. Now you can start hearing the chattering. And that means that we might be approximating the right size. So just withdraw it. So we are now withdrawing it, and as we withdraw, we want to ensure that our guide wire is not out. So your assistant is going to hold the guide wire and then the guide wire, and then we check it again on the tip. That means that there is no proximal withdrawal of the guide wire. So now we are reaming up to 11 and we are getting a frank chattering. You can hear this voice. So when you start hearing this noise, that is the upper limit of your reaming. You don't want to ream any more than that, because all you are going to do is either cause fragmentation or an anterior bow of the nail. So go slowly and pass the nail.
Okay.
So initially, if you have reamed well, so what I recommend is, if you are going to put a 10 nail, you should ream at least 10 or 11 or 11.5. So you should ream at least 1 to 1.5 larger than your choice. So now we have checked our nail position. So this is a guide which shows where our nail is. So this is just at the level of the GT, which looks good, and distally it is just below the inferior pole of the patella, and the nail length looks pretty good. And we look at the fracture site. So the fracture site is also very well reduced. So we are going to proceed with the proximal locking. So in order to make your skin incision for your locking,
You see here, the nail is inserted and the tension on the skin and how it has to push the skin medially to be able to insert it. It is not the problem with the surgeon. It is the problem with the position of the patient and the design. We cannot change the position of the patient because we have no control of the distal leg because it is fractured. It must be aligned with the body. So this problem has always been present with the femoral nail, and somebody has to change it. Okay, I wanted to show you one of the problems we have with these devices. Okay, so you have one VR module to practice on. Since this is the first one, you may have some problem, you have some questions. If you have any problem or question, please ask me or the support of the, if there is something related to the software, ask the support of the software. But if it is about the procedure or anything that I can help, don't hesitate to ask me, so you can use the platform easily and perfectly and make the best use of it. So if you don't have any question, please try to use the headset whenever you have time. Think of it more as a game than homework, okay? And See you tomorrow at 5. Correct? And just for your information, tomorrow is the last, tomorrow at 5 is the last session that I am the speaker of the emerging topics. From the next week, there will be other speakers, surgeons, engineers. There will be other people that will have some presentations for you. So see you tomorrow at 5.
See you tomorrow.
Okay?
Have a good night.
See you.
See you tomorrow,
Have a good
Professor.
night.
Thank you.
Goodbye.
Bye.